all, dear physios, I will talk about the practical issue, the second part after the theoretical part. First of all, we will talk about the instrumentation, the machine itself. Regardless the type of the machine and the commercial version, there is standard parameters for any machine. First of all, it must to have amplifier. This amplifier, it will be connected with cables. Also, it will be connected with the laptop or the PC. Always we have some connection of certain wires I will talk about later. This machine inside, any machine, we have a rejection ratio circuits, which is have its filters. Any machine we have in the room ambient noises. These noises, it will interfere with the findings we will get from the electrical shock for this patient. Any undesired waveform that interfere with the findings and the waveform that we cannot interpret this waveform properly. So any machine will have rejection ratio from 1000 impedance ratio till 100 hertz, from 1000 to 10 hertz for EMG, 100 to 300 hertz for sensory, for F-wave. So we have a chart, this chart getting the ratio that will adjust before any protocols. Anyway, any machine, it will standardly have its ratio to reject any low rejection ratio filter and high rejection ratio filter. Okay. Any machine has its knobs, buttons. These buttons we can use it to directly access and easy access to certain protocols, certain measures. If we're dealing with the motor fibers, if we're dealing with the sensory component, if we're dealing with the F-late, proximal bar, if we need to enter too fastly to the needle EMG, to single fiber EMG, to Planck reflex, anyway we can adjust these knobs. Just we see F2, F3, 4, 5, 6, 7, these measures or these buttons, it can get a direct and easy access directly to certain protocols. You can adjust this machine. We have this yellow one dot. This is a single shot electrical stimulation. Basically, we're using the direct stimulation, galvanic stimulation, direct stimulation to hitting the nerve, any nerve. The second one, 3 dots, these 3 dots, we can use it repetitive, especially a repetitive nerve stimulation. If we need to multiply chop this nerve, the less one is 10 repetitions. This is in E, which is the impedance. Impedance, we can use this E icon or Z icons to see what about the any electrodes, and this electrodes connected with the skin of this patient. The cup electrodes, when it adhered to the skin of the patient, it will contact or not. If we have any problems in the skin, any sweat, any cream, any bad skin, you can adjust and remove this impedance to will get the proper improvement for the trace or waveform. The second part, we will talk briefly about the motor nerve conduction study. So I will say motor nerve conduction study. Motor nerve conduction study, I will hit or strike the nerve. For example, the median nerve, the ulnar nerve, radial nerve, musculocutaneous nerve, axillary nerve, spinal accessory nerve, any nerve I want. So I will hit this nerve and getting the waveform or the action potential from the muscle itself. So basically, any nerve, it must do recording from the more distal muscle, not the proximal muscle. This rule we can some times we can do some changes if we the problem of this muscles of this nerve, sorry, is the proximal. Let me explain this practically now. If we can imagine this is the median nerve. The median nerve, it will getting the origin from the lateral cord C5, 6, 7, and also from the medial cord SC8 and T1. So the values or roots of this nerve is all roots from the brachial plexus. Okay, this is the proximal part. Then it will be getting down from the clavicle. It is this component. It will talk about the brachial plexus, and then enter to the axilla, and then it will be getting its take off as a peripheral nerve after getting out from the axilla. So this median nerve, from after get right from the axilla, it will be getting branch at the arm level. This branch at arm level cannot get any branch muscularly at the arm. So this area, it is for musculocutaneous nerve, biceps, and the brachialis muscle. Yes, this is make a sense. So any problem can be hitting the nerve at this mid-arm. Yes. What is the mostly problem we can facing in the median nerve at the mid-arm? It is the transverse ligament, like this yellow band, yellow wire. This is transverse ligament underneath the median nerve. It will be getting its branch and then go through underneath the transverse ligaments, be trapped, can be trapped underneath the transverse ligament here at this point. This is great. And then it will be this median nerve after merging from the transverse ligament, it will be getting to the forearm level. When enter this forearm level, it will be cross between the two heads of the pronator teres. Yes, this pronator teres, after getting through the pronator teres, it will be getting change its name from its mixed nerve, sensory and motor. It will be getting a pure deep median branch. What about its name now? It will be get anterior interosseous branch, which is a pure motor. No sensory branches at this level after getting through the both heads of the pronator teres. So at the elbow level, it may be trapped or interact at this pronator teres two heads. Then the anterior interosseous at the forearm level, getting no any sensory branches except a palmar cutaneous branch. This palmar cutaneous branch, it will get above about 4 fingers, 7 centimeter to 9 centimeter above the proximal crease, and this sensory branch get above innervation the transverse carpal ligament. So the path, it will be above the transverse carpal ligament and get sensory innervation of the skin at this part area, this area. So any pathology affecting the median nerve proximal, it will be affecting the sensory component at the palmar level, which is the palmar cutaneous innervation. So the patients will getting some clinical signs. Yeah, I have some itching in this area. So I will ask if we have a numbness at the 3.5 fingers, which is the terminal sensory territories from the median nerve. The patient getting no, just I had some itching and some and this palm area. So your query and your clinical diagnosis, it will be proximal interabdomen syndromes, all pronator teres syndrome affecting the anterior interosseous as well as the palmar cutaneous. But if the patient has or getting the anatomical pathway, the median nerve getting below through the transverse carpal ligament, is a carpal tunnel with 9 tendons. This 9 tendons getting beneath, underneath, below, and getting a very tiny branch. This very tiny branch just before the outlet of the carpal tunnel. What about this terminal branch? It is a recurrent motor branch. Recurrent motor branch, thinner motor branch. This thinner motor branch getting innervation for the all three muscles of the thinner eminence muscle, abductor pollicis brevis, and then flexor pollicis brevis, and then the opponents pollicis. So the main innervation of the all thinner eminence is the recurrent motor branch, like that. This is the optimally position of this recurrent motor branch. And then getting a terminal branch to the lumbricals, here, second and third lumbricals, which is supplied with the middle nerve, the fourth and fifth was supplied with the ulnar nerve, but all interosseous innervation supplied with the ulnar nerve. This is make sense. So let me getting this image for the physical therapists or any health providers that dealing with this patient. This terminal sensory territory or axons for the fingers. This is the terminal branch for the radial area of the thumb, which supplied with the median, but the ulnar side is supplied with the superficial radial. Yes, this is double supply from one branch sensory from the median, one branch sensory from the superficial radial, which is a make sense. Yes, is the first. The second one is the index. It's doubly innervated sensory territories, centrocollateral branches for the index, for the middle finger. This is purely supply of the sensory part of the median nerve. The ring fingers, it's branch supplied with the median, and the other branch supplied with the ulnar, and the little finger, all two terminal branches supplied with the ulnar nerve. It's perfectly, we're getting this. So the main rule when do a conduction study for the median nerve, which is a long nerve, it must, as Robin Devon said, it must get distal stimulation at the wrist, proximal stimulation at the elbow, mid-arm stimulation like here, and then air point stimulation like here. So the question, it must to get the 1, 2, 3, 4 stimulation. Yes. Why? Every side can be getting different pathology. So when getting all the 4 CMAPs or the 4 conduction study or the 4 action potential, this 4 action potential getting the image about the entity or the whole length of this nerve. Great. If we want to start to getting a more obvious trace practically, it must, you see, this is the briefly the chart. I will put the full data about the name of the patient, Islam, Samaha. It is male or female. It's very important because we have some female pathology, some male pathology predominant, and also in dealing with a female, we must not take further stimulation intensity rather than the male. Second part or third part is the birth date. The birth date is very crucial, very important, and mandatory. Why? If we're dealing with the patient above 60 years, logically make a sense in we have some abnormalities in conduction velocity, some abnormalities in the latency. This latency or this abnormality is related to the age. So when referring to the patient clinical data, we will getting a pathology, in fact, or in date. But this is correlated with the age abnormality. So it will be ignored, not taking your considerations if we have conduction velocity reduced, but we have no clinical consistency with this patient. If we have greater than 60 years old. Again, if we have a child below 30 years, it must to getting half of the normal adult value. This is the 2 parameters I will take in consideration. So I will getting any date, and then this is the referring any healthcare providers. So I will say a physical therapist now in EBTA getting a whole entity for our profession, and we can use electrodiagnosis as a single unit in your healthcare career, professional career. You can use electrodiagnosis as a referral from the neurologist, psychiatrist, internal medicine physician, family physician, and also dermatologist, in some cases, dermatomyositis, like so, and also a neurosurgeon, orthopedic surgeon. It can be referred to you as electrodiagnostician to getting a clue or answer for the query that I will get for this patient, and getting a nourished report, and this reporting can solve this problem and take a decision making. So this is the referred icon, and this is the chief complaint. It must be put in very simple, like numb hands, acroparesthesia, radiating pain, generalized weakness, tingling paresthesia, facial pulse, post-gunshot lesion, weakness of the upper limb, focal weakness of the thenar. It must be briefly getting this chief complaint. So I will selecting the numb hand, and I'm getting this, open the machine. Okay, if we get mouse on the M, it's a motor conduction. So if we think this, I will see median nerve recorded from abductor pollicis brevis, right or left. Ulnar nerve from the abductor digiti minimi. Radial from the extensor indicis proprius. Ulnar, we can recording from the first dorsal interosseous in Guyane entrapment. Median, for the recurrent motor branch, which is a very crucial. I will getting a more in-depth clarification for this branch of the median nerve at the ball. And also we can recording the ulnar nerve recording from the elbow, but recording from the muscle flexor carpi ulnaris, if the problem at the elbow level. Why are you recording from the abductor digiti minimi and go through the all nerves, nasalis facial, nasalis pudendal nerve, suprascapular nerve, from the supraspinatus, suprascapular from the infraspinatus, and also peroneus, tibialis, orbicularis oculi, orbicularis oris, if we're getting branching from the facial nerve in some specialty, needing to please examine the facial nerve and its all branches, especially in plastic surgery. Okay, this is the left hand, this is the median nerve. I will getting check the left median nerve. So first of all, it must take care the time, Dr. Hassan. Okay. Okay. First of all, it must to put in the ground one, which is green. The ground, it differs from the ground from the machine. Some machines, especially in USA, like two brands, it must be sets, especially the amplifier, it must to be getting direct connecting to the electricity. So any electricity without earth in the building, it will getting indeed a noise. This noise interfere with the readings I will get. But if most like the advanced machines, it's getting inside some circuits and some rejection circuits that dealing with the ambient noises. But from this stimulus, me I getting some noise till reaching the recording. This ground will getting right of this noise. The recording cables, it must to be clear, to be familiar with. So we have some cup electrode. This cup, like spoon, okay? This cup electrode, it must we use it with the motor conduction stud. So I will get this.
Excuse me.